Let's respect everybody's time. So good afternoon, everybody. We are a small and intimate group, as we can see, but thank you all for making it here. So at least we can say the audience equals the number of presenters, so that's great. My name's Mike Suter. I'm the moderator here. We have a great panel to talk about some, I think, intriguing questions. I'm going to, this is our speakers here today. I'm going to lead off just, setting the stage for talks. You're going to hear first from Shala, who's going to talk about the revised ASA DNR guidelines and the ethical premise. Then Alok is going to talk about managing operational issues, and finally, Mariah is going to kind of bring it up with practice and principles around the world. Thank you for closing this door there. So I just want to offer two scenarios. The last presentation in this room, I kind of sat in on that. It was actually really very poignant, but very applicable to this scenario, which was about the honesty that's required in managing end-of-life scenarios. And end-of-life scenarios are increasingly there because we're presented with managing these patients in a day-to-day fashion. You may think, well, when you look at the premise of this, the EGD patient, how likely is this that I'll be called upon to do this in some DNR? But here's just two, I think, very believable scenarios that may come up on your daily schedule here, both in a kind of more elective session of thinking about the man with amyotrophic lateral sclerosis who needs something done so as to promote his capacity to eat when offered as a palliative measure. And he can't swallow secretions, he's choking there, and so gee, I want to do this urgent. So I'm mixing this is the more acute scenario there. Gee, I want to do this more urgently, and requesting anesthesiology support. And whereas in the woman who's got esophageal adenocarcinoma with metastatic spread, there they want to place a stent for palliation and requesting general anesthesia to facilitate that. But in both those settings where you think, okay, these are pretty bleak scenarios, these are people who are inevitably facing their own mortality here, how much more can be done with them? But certainly they've both signed do not attempt resuscitation orders. And your challenge is, how do you deal with this? You say, well, why me? Why am I involved with this? There are, that's a question perhaps to be answered more in the abstract. But certainly when you're dealing with this here and now, here's a patient who has a do not resuscitate order. What do I do in this setting of perceived perioperative frailty, significant complications, kind of bleak prognosis? How do you approach this question of handling the DNR order? So it's easy. The ASA has a statement on what to do. Great, we can all pack up and go home. It's all done, okay? And statements out there, you can go Google it and have a look on the ethical guidelines for anesthesia care of patients with do not resuscitate orders. This first came out in 2001, and we actually set the stage. I'd just like to say this is a rare occasion where anesthesiologists can say, yeah, we got this right before anybody else, before the ARN, before the American College of Surgeons. And so we've just continued reviewing this statement. And there is a process of periodic review that undergoes, that came from the Committee of Ethics, of which we for all, actually three of us are members there, and I'm just the immediately departed chair just from yesterday. And so we had this job of reviewing this document, and I actually thought in my naivety, oh, it's a slam dunk. Yeah, we'll just reaffirm it. We'll just say, yes, this is the right thing to do, which the position taken by the ASA is one of required reconsideration. We have to go back to the patient and present options there, not presenting them a cookbook of, do you want this procedure? Do you want that procedure? It's really more to kind of get at what are their goals? What do they want to see as a conclusion of any immediate need for resuscitation in this circumstance? So as I said, my naivety, I brought this up before the committee, and those, two of the committee members there may remember the fact that it wasn't a quick 5-minute discussion. It turned up into a much more protracted argument with, I think, some valid questions on who knew this policy was out there, even amongst the committee. Amongst bioethicists, there was people who said, well, I've never actually heard of it. How much use is it if we haven't actually heard of it? So, this was the focus of discussion. We decided to educate ourselves, essentially, by asking everybody else. Let's ask the wider community what we should do, in terms of actually handling this document and undertaking any necessary revisions. So we circulated a questionnaire to the wider community within the ASA in August and September of 2023. And the questions were designed to assess awareness and prior experience of the ASA guidelines. Did you know they were out there? Do you have anything comparable in your institution, and are you using those? And presenting them with some hypothetical scenarios of urgent cholecystectomy as a scenario where patients had an existing DNR order but varying levels of capacity. And perhaps some of you remember that. Hopefully you all can respond to that, and thank you for that. I appreciate that, because you would then be part of the 8.3% who responded. Now, you may say 8.3%. Believe it or not, that is a good result when it comes to an ASA questionnaire that goes out. Yeah. So we were actually pretty cheered by this. I was initially despondent, but then told by ASA administration, that's actually not a bad figure at all there. You should be happy with that. So we got these results there. 39% of our respondents were actually aware that the ASA had guidelines. That was disappointing. But good news was that over 90% of those who actually were aware of them and had found them useful in these settings there. 71% were aware that their institution actually had a policy on this. Concerning perhaps in thinking about the 29% who didn't, where were they going to for their advice? But of those people who were aware of the policy, 90% of them had used these at least once. So you can perhaps extend the premise that those who weren't aware of the institutional policy had never developed a need, perhaps. When we looked at what the component parts of their policy was, 40% of them mentioned reconsideration of orders, 66% of them, and this wasn't either or, this was, you could actually include options here. 66% of them, required review of goals of care to guide degrees of resuscitation. 62% also thought about what different resuscitation measures might be perceived of as acceptable to the patient, presumably with discussion ongoing as well. And surprisingly, 28% still included the principle of automatic rescindment. In other words, if you're coming to the OR, your DNR is revoked. Now, no professional society currently agrees with this stance. So that's why it's so surprising to actually see this, still in persistence with that. And what's even more concerning is within those groups of people who said we automatically revoke, 4% of them said, well, we just don't tell the patient. Now, you may say it's only 4%, but still, that gets everybody's hackles on edge about patient's autonomy. Perhaps even more challenging to this was if patient's value is different from the patient regarding DNR, while the majority would accede to patient wishes, 17% would transfer care to a colleague, because, okay, I'm not comfortable with this, but I'm going to get my friend who will do that instead. But 9% would just refuse to provide anesthesia altogether. And when we looked at the hypothetical scenarios, without going into unnecessary depth, similar proportions reported across all those. So what did we learn? Well, we learned that what we presumed was a settled question was in fact much more complicated than we'd thought in terms of people's attitudes and awareness out in the community. We learned that a minority, but still surprising proportion of institutions still have automatic rescindment in their policies. And over 9% of anesthesiologists would refuse to provide care if their values differed from that of the patient on DNR. You may say it's only 9%. That still troubles me that 9% is still there. So what's the way forward? The role of the Committee on Ethics, certainly, and I actually argue that probably most of us, we don't want to police thoughts. We want to educate people. So this is what we perceive as a way forward. We published the results of this questionnaire. This drove the publication of an article in anesthesiology, which again came from this committee on ethics there. And we're undertaking presentations of this sort to try and raise awareness of this issue and get people to thinking at least, what would I do when I'm in this particular situation? So we educate ourselves, we educate each other, we discuss, and hopefully from that, by the time we're actually ready to kind of come round and review these principles again, we will have derived a better sense of what the consensus is in the community. So with that, I'm actually going to stop, and I'm going to kind of turn it over now to our panel, who are actually going to kind of deal with perhaps some of the kind of the more in-depth considerations here with this. So I'm going to start with Dr. Siddiqui.
Thank you. Again, thanks for coming to this, one of the very last sessions. I'm Shala Siddiqui. I'm an anesthesiologist, intensivist, and bioethicist at Beth Israel Deaconess in Boston. And so I'm part of the ethics committee at ASA. And as Mike said, that we had one group of us who volunteered to look at the survey and the results of the survey. And another group of us decided to look at the ethical premise behind the guidelines and what we are recommending of what ought to be, not what is and what's happening. That's what the survey showed, the snapshot. But what is the ethical premise of DNR guidelines and how an anesthesiologist should deal with that? So these are the guidelines, and my only conflict is that I am a second author on this publication. Other than that, I have no other disclosures. So the evolution, first let's go back and look at the evolution of the DNR order, the Do Not Resuscitate order, and there's a little bit of history. Origins of CPR and the need for it. Why was it required? In the 1960s, CPR became widely used in hospitals after the development of closed chest cardiac massage. And initially, CPR was applied universally to all patients with cardiac arrest. There was no such thing as, I'm DNR, do not resuscitate me. Everybody got it if you were in the hospital. The problem was that physicians soon realized that CPR was not appropriate for all patients, and you can imagine the scenarios where it was not appropriate, particularly those with terminal illnesses, advanced age, or poor prognosis, and CPR could prolong suffering without meaningful recovery. Emergence of DNR orders started in the 70s. Hospitals began creating do not resuscitate orders to prevent unwanted resuscitation attempts. And early DNR policies were often vague and physician-driven with limited patient or family input. Nobody asked patients or families what they wanted. They just thought, this person is appropriate for resuscitation. This one should not get CPR. So it was really very paternalistic. The concept of patient autonomy began influencing these DNR policies like it did everything else in the 70s, emphasizing that patients could refuse life-sustaining treatment, including CPR. Mind you, the quality of CPR at that time wasn't very good. There was just I think 1 or 2% survival rate, anybody getting CPR. In 1976, there was the Quinlan case, which was a famous case, a landmark case in the U.S. Supreme Court, which highlighted the right to refuse life-sustaining treatment, not really just CPR, but any life-sustaining treatment. In this case, it was a young woman who had a tracheostomy and was kept alive on the ventilator for a prolonged period of time, and there was a legal battle between one surrogate and another surrogate decision maker. Although CPR was not central in this case, it set a precedent for what would the patient have wanted? What is patient-centered ethical decision? 1980s, the ethical framework started sprouting up, and Thomas Beauchamp and Childress, the famous ethicist, wrote the book on principlism, which is basically the 4 pillars of ethics, bioethics, which are autonomy or patient preference, beneficence, and non-maleficence, and justice. And they became integrated into this DNR discussion. Physicians were encouraged to discuss prognosis and options with patients and their families and decide about what they would want at the end of their lives. In 1991, the American Heart Association issued formal guidelines recommending that DNR communication should be documented and respected with patients and families. Then the PDSA came around, which was in 1994, and this required healthcare facilities to inform patients of their rights to accept or refuse treatment, including CPR and DNR status. So here legislation comes in. So not just a guideline from the AHA, but now it's in the law that you have to have a code status for patients. In 1990 to 2000, early 2000s, hospitals developed standardized DNR forms. So that you had yellow forms or orange forms, et cetera. And they would include allow natural death or DNR policies. And terminology in some of these were uniform. In other places, it's different terminology. But it started becoming more clear and patient-centered, and the communication documentation started becoming more clear. DNR orders are historically suspended during anesthesia and surgery. And if you go around asking urgent care centers, daycare centers or GI suites or nursing administration, they will say, of course, DNR orders should be rescinded. In fact, when in some centers, in my center, when they call down for the patient to come down, the nurse will, at the reception or the unit clerk will ask, is the code status full code or not? Meaning that is a prerequisite for the patient to come down, just like the NPO status. So that is how much entrenched this idea is of rescinding the DNR order. Now, the ethical tension arises when there is automatic suspension versus respect for autonomy. Where is the patient's preference in this? ASA guidelines were revised earlier on to say that they should address modern ethical standards. And the ethical premise was the central value should be patient autonomy and informed decision-making to avoid paternalistic override by clinicians and promote shared decision-making about perioperative resuscitation preferences. Now, not highlighted in this is that it's not always the clinicians or the doctors who are behind this. It is very often the operative feasibility by nursing, by administration, who don't want to keep a daycare area open after hours if you have to resuscitate a patient, or if they're allowed to pass away in the OR, how would they manage that in a very busy GI suite? It's just not feasible in some of these places for that to happen. But the ethical focus remains, and the ASA guidelines were revised, and that's why this paper came out last year in anesthesiology, where we talked about ethical focus revisions, the clear definitions of full code, DNR, and allowed to live, shared decision-making between the healthcare providers, patients, and families was stressed, consideration of the quality of life, prognosis, and patient values, how to have those discussions, what to say, what should be the verbiage around these discussions, and most importantly, who would do these discussions, the required reconsideration. Most GI clinicians are not the primary team when they bring down a patient, especially if they're critically ill or they're in the MICU, etc. These doctors who are performing the procedures are just the proceduralists. They're not the primary team. So do they have the conversation, or does the anesthesiologist, since we have the overarching ownership, so to speak, in that area of the patient, or does the primary team, before they send the patient down, have that discussion? DNR orders are now often part of a broader goals of care discussion in the ICU. It's not just CPR. It's not a menu. You talk about what is the expectation in a setting where the patient's death is imminent, or there is a question about prolongation of life. An international perspective is also there. While policies differ by country, the underlying principle of respecting patient autonomy and avoiding non-beneficial interventions is universal. So the core revisions in the ASA guidelines that we published were rejects automatic suspension of DNR during anesthesia, requires preoperative discussions about resuscitation status, encourages individualized planning based on patient goals and values, and how do we clinically apply this? Surgeons, anesthesiologists, and patients must negotiate a scope of resuscitation. And any proceduralist must have that conversation. So even if you are not the primary team, it behooves you to actually have that 1 minute or 2 minutes of actual scenarios. This could happen, and this is what what are the options that we can do, and what fits into your goals of what you would like, what you think would happen to you in your trajectory. Goal-directed resuscitation is aligned with patient values, example, short-term versus long-term interventions, and documentation is key, of course, as in everything else. And here are the 4 principles. These are at stake. Some of the diagrams or figures from that article are here with the reference. If you want, you can look at that. But basically, setting up the discussion, exploring options, recommendations. So remember, when we talk about goals of care and patient-centered care and autonomy, that does not mean that we cannot recommend something. It's not paternalistic to offer guidance or recommendations. This is if it was my loved one, I would recommend this, is an option that I often use. And patients and families, having been a family member of an ICU patient, my mother, it's always very comforting to have that guidance. Even though I'm a physician, it's always comforting to have that. So I often, first of all, forming that trust and that bond is important with your patient's family. Even if you're just meeting them for 1 5-minute brief moment, it's important to have that. But it's important to really get invested in their decision making and not just offer them a menu for them to choose, and then document it. Again, there are levels of CPR, routine, which is basically your ACLS, preemptive, meaning you're trying to protect them before an impending instability, and then comprehensive. And then the practical challenges, as I mentioned, implications for practice is this is a very fast-moving, high productivity environment. And if you are going to have a patient who is DNR, they may pass away if their EF is 2%, and you're pushing some propofol. This might happen. What are you going to do? So that contingency has to be taken into account. And then finally, which area, this diagram gives a nice illustration of the roles of various teams in different areas. And finally, it reflects a shift in medicine towards shared decision-making and aligns perioperative care with the broader end-of-life ethics, balances technological capabilities with humane care. And in conclusion, these guidelines respect patient values, and we move away from blanket policies to nuanced, individualized care, honoring autonomy while ensuring safe and compassionate practice. So with that, these are my references. Dr. Allen, who was the primary author, could not be here at ASA, and really I'm presenting for him. But any questions at the end, please?
Okay, hi, good afternoon, everyone. My name is Alok Gupta. I'm an associate professor of anesthesiology and critical care at Northwestern in Chicago. I do not have any financial disclosures today. And today we'll understand some of the operational issues of how do we implement this in our institutions, and, a perioperative DNR, and the discussion around that. Some of this will be a little bit of a review, but obviously we have the principles that guide the ethics of beneficence, non-maleficence, respect for autonomy, and justice. And we're really talking about that autonomy piece. Again, we've heard that a DNR order should not simply be suspended because of a change in venue of care. When a patient who has a pre-existing DNR order is to undergo an operative procedure requiring general anesthesia, bronchoscopy, endoscopy, the physician should discuss the rationale for continuing or temporarily suspending that order with the patient. When we talk about do not resuscitate or DNR, though, what are we really talking about? So, the self-determination and healthcare-related issues, if you think about it, it's really one of the only orders where we're saying do not do something, do not treat the patient, right? And that's something that goes against us as, physicians in terms of treating the patient. So it's something that you really have to think about. From that standpoint. Again, that right to self-determination, but one thing I want to just clarify is it does not imply diminished medical care, and it does not imply the wish to withdraw, withhold, or de-escalate therapies in patients, and that's a common misconception that I see with patients. Every state is a little bit different. There is this POLST document, or Practitioner Order for Life-Sustaining Treatment document. May be called by different names in different states as well. It is a mobile document about advanced care policies, a process with an individual does this with a trusted healthcare practitioner. It must be signed by a healthcare practitioner as well. At least in Illinois, healthcare practitioners are required to honor a validly completed POLST form with patients. So we do ask the patients for that. This is an example of the one from the state of Illinois where it says, am I DNR, do not attempt any sort of resuscitation, or do I want some sort of selective treatment that goes along with my goals or my values? Going back to the document that Dr. Siddiqui already talked about, this paper provided a nice workflow for the integration of a multidisciplinary team regarding perioperative cardiopulmonary resuscitation in patients who they defined as having serious illness, which you can see in the top right corner there. So, it's really once a patient is identified as having a serious illness requiring surgery, there should be a discussion of those goals and those care. Should the patient go to the ICU? Should they not go to the ICU? Should there be an interdisciplinary conference talking about that patient before heading to the operating room? And of course, these are situations where we have the luxury of time. As anesthesiologists, we sometimes don't have that luxury. When talking about that multidisciplinary approach, obviously, there's the surgeon or proceduralist, perhaps the primary care provider and the anesthesiologist. But sometimes, we can optimize patients before coming to the operating room as well. That's where we may need to get nutrition involved, physical therapy, or a social worker involved as well. Again, looking at this kind of timeline, looking at that y-axis here, we are the physicians who probably have the shortest relationship with the patient throughout the perioperative period. But we are often the ones who are having these conversations with the patient. And so it is important to involve other people throughout that process. So how do we actually go about, kind of instituting this? And if your institution's anything like my institution, you have to have a policy. Nothing happens without a written policy. So this is an example of our policy that we have addressing code status, and this is throughout the hospital, but there is a section on intraprocedural code status summarized here. So, saying that it is the responsibility of the surgeon, anesthesiologist, or proceduralist to document the discussion and the plan with the patient. The plan should be goal-oriented among, the patient, the surgeon, and the anesthesiologist. And if the DNR is rescinded, the order must be canceled in the EMR and replaced with a full court order and then reinstated at some point post-operatively. And that point can be a moving target depending on, the patient and the discussion with the patient. Also from our policy, if a consensus cannot be reached, we have other resources that are available, our ethics committee, patient relations, palliative care, spiritual care, et cetera, to help. And then lastly, making sure that our staff are comfortable. If the attending physician may withdraw from the case, providing somebody else will accept the patient if they're uncomfortable and it goes against their values and beliefs. Looking again, at the do not resuscitate order here, again, looking at any vulnerability for the patient and discussing the code status. And, when discussing that perioperative code status, it's not just full code or do not resuscitate. There can be areas in between. So, we can have a full attempted resuscitation, a limited attempt with respect to goals, and a limited resuscitation with respect to procedures. When talking about respect to goals, it allows the surgeon or proceduralist and the anesthesiologist to exercise some sort of clinical judgment regarding what resuscitative procedures are appropriate based on the patient's goals and values from that preoperative discussion. And with respect to the procedure, it elects, the patient to provide specific procedures, or even the surgeon to provide specific procedures to say, this patient would not be an ECMO candidate based on their goals and values. Just as an example. We've implemented some EMR facilitation for this. So this is at the end of all of our preoperative notes for patients coming to the operating room that we need to fill out, talking about peri-procedural code status. It serves as a visual reminder for us to look at what is that code status for the patient and perhaps have that discussion with the patient if that is. And if we choose limited resuscitation, you know, we can say that procedural versus goal-oriented discussion, and then who we talked about, and what are our resuscitation limits for that patient. Then we also have a free text area we can document a further discussion for this. You know, there are some examples of courses out there on how to teach this. So this was a study that was done with the anesthesiology residents comparing an online video of teaching perioperative goal discussion, and it showed that there was an improvement in a standardized OSCE in terms of having this discussion and the documentation of that discussion. Going back to this slide that we saw here, so again, you know, it's really a continuum of, you know, starting at the beginning of reviewing documentation of the patient, you know, seeing do they have, you know, some sort of written order, making sure that we involve maybe not only the patient, but some sort of licensed caregiver as well, depending on the capacity of the patient, et cetera. You know, setting up that, exploring, you know, asking about goals, priorities, you know, do they want to get home? You know, what do they want to do? Making a recommendation again, and then documenting that discussion. Some of the challenges, you know, is where to have this discussion, right? I mean, again, as anesthesiologists, we're often meeting these patients in the preoperative area. You know, could that be considered coercion, potentially? You know, having that discussion in that area is something that I always struggle with. You know, patients sitting there in a hospital gown with an IV in place, you know, ready for this procedure, and then all of a sudden we're saying, hey, if something happens, do you want us to revive you? Who has this discussion? Again, is it the anesthesiologist? Is it the proceduralist, the surgeon, all of the above? Making sure all team members are on the same page. So at Northwestern, we do a pre-induction of anesthesia timeout where we would discuss this to make sure that everybody in the room, the circulator, the scrub tech, everyone is involved, because we don't want to put anybody in an uncomfortable position. And the patient is usually awake and not received any sedation at this point. And then who discontinues that order, right? Is it, again, the anesthesiologist? Is it the surgical team? Because that plays into who's going to replace the order. You know, if I'm post-call, you know, I had this discussion, I get relieved, patient comes out of the OR and PACU, I'm probably not going to be the one to replace that order. So that needs to be clarified. Is it going to be the anesthesia team or the surgical team? And then when does that get reinstated? You know, is it when the patient leaves the PACU? Could it be when they leave the hospital? I think it's a case-by-case basis. Or does it even get reinstated? You know, did the patient go into the surgery thinking they had an uncurable disease, and then they were able to cure the disease and they no longer want to be DNR? You know, so it really should not be an automatic reinstatement of that order as well. And that is all I have.
You guys are hanging in there great. I'm Mariah Tanius. I'm a pediatric anesthesiologist, end-of-life researcher, and bioethicist currently at the Medical University of South Carolina. And I have zero disclosures for you other than this is part of my life and work, and I've worked around the country and the world a lot. So thank you guys for joining us. In this final section, I will show you that if we think we have challenges in the United States, there are challenges elsewhere. And this may be the one area where America is at the forefront and has been doing a lot of good work both on our professional guidelines but also on our legal statutes. So we'll explore a little bit the global landscape of what laws and professional guidelines look like around the world relative to DNR orders, and we'll see that there is considerable country-to-country heterogeneity and perhaps a different interpretation of our central ethical principles. On a global scale, there are countries like the U.S. that have both strong delineation of DNR laws, but also in physician self-governance documents. There are other countries like Japan or Italy that have professional society descriptions of how to manage these orders, but no applicable statutes, or other countries like Sweden or more recently UAE that have laws but no professional guidelines. At least in what's publicly available, those sources, Singapore and China are without either professional guidelines or really legal statutes. In Singapore, they do have laws around advanced medical directives, but these comment on future decision-making for an incapacitated patient. The DNR decision is really felt to be a clinical one at the bedside, and so no law or professional statute is really commenting on it. In China, they have their National Physician Society, which publishes general professional codes in a code of ethics, but there's only laws in some cities, and it's far from universal. And so the DNR decisions are kind of up to debate, though they happen at the bedside. Even in countries with well-established laws or guidelines, there's still great variability in how well practice aligns with these different guardrails. We can see in our own country the huge variability, as well as even places like Sweden, which we would consider very medically advanced and perhaps on the forefront. In 2021, there was a study that looked at physicians, and they found that physicians failed to fulfill all the requirements of Swedish law around DNR orders in greater than 90% of cases. Even when we look at our act here back in the 1970s or 1994, the Patient Self-Determination Act, 20 years after that, in 2014, there was a British court case that determined that physicians had a legal duty to tell a patient with capacity the DNR order had been in place. So in Great Britain before that time, the court had determined or physicians were often placing DNR orders and not even informing patients and feeling that constituted reasonable practice. In many international medical contexts, patients and family preferences are treated with more of an advisory role. There's kind of a de-emphasis of this right to self-determination or of patient autonomy, and there's more of an emphasis placed on beneficence and non-malfeasance from the provider perspective, which is fascinating. That overriding agency can be bidirectional, so you might see a physician who would override a patient's DNR and unilaterally reverse it for the OR, or you might see an ICU physician who considers the patient's prognosis so grim that they unilaterally instate a DNR order and may or may not tell the patient or family. Multiple studies have commented on these trends. There was a 2003 study of Italian intensivists that found that more than half of the Italian intensivists would not involve the patient in a withholding or withdrawing therapy decision, even if that patient was competent. So a little bit of concern, and especially when we stack on this, we know when you look at both international and American studies of providers' decision-making, it's variable, it's prone to bias. It depends on that provider's age, their faith background, their culture, their language, their experience. And so that happening in a vacuum of the patient and family values can be problematic. This chart is adopted from one of the few peer-reviewed pieces evaluating DNR orders around the world and adjacent end-of-life care. The highlights include some of the cultural differences in the views of death, the ideal location of death, but primarily the ability of physicians to be the unilateral decision makers regarding the appropriateness of resuscitation. Certainly that exists a little bit in the United States. If you truly feel that CPR is physiologically futile, we have the right as physicians here to practice kind of professional autonomy and say that won't accomplish anything, the physiologic futility component. But in some countries with legal statutes describing DNR orders, the physician retains a right by law to be the primary decision maker. And in some of these laws, it says your secondary provider could just be the bedside nurse. And if they agree with you, it's a done deal legally. You're recommended but not legally required to involve the patient in many of these countries. If we zoom into low and middle income countries, there's very little data on formal DNR use in these regions. We know it's happening, and what little data we have suggests that many of the logistical constraints, multi-level barriers exist in these countries, though ultimately many of the clinician-driven DNR decisions mimic that of higher income countries as well. A study back in 2015, providers note universally that DNR is an essential component of end-of-life care even in these regions, but also note that using it effectively is supremely challenging. Transitioning now to the global professional guidelines, of which the most widely used and publicized are the European Resuscitation Council guidelines. This is written by an ethics and resuscitation writing group, which is made up from clinical experts around different European countries including Serbia, Cyprus, Denmark, Belgium, Czech Republic, Sweden, Netherlands, the UK, and Greece. These are their latest published versions, which don't have explicit DNR, perioperative DNR management guidelines. But they do integrate many of the tenets and principles that are cited in the American perioperative DNR guidelines, one of which being that CPR should not be universally provided, that we should be doing this discriminately and looking at harms and burdens and realities, similar to those articles we saw that you might triage by age or ASA status or existing frailty. It describes a global shift from sheer futility assessments to more of a best interest approach that must forcibly integrate patient values, preferences, and background, and then globally condemns any sort of slow codes, and that is one that we can hold and take home, is that slow codes no one should be doing anywhere in the world as an ethically problematic approach. When we pivot to the draft version of the 2025 ERC guidelines, which are set to be published in the next 2 weeks, this version really outlines the importance of ensuring that people receive goal concordant care that's consistent with their values, their preferences during serious and chronic illness. This new draft also doesn't eliminate the need of DNR policies and education in low resource settings, and even talks about both the evidence base, but also the ethical permissibility of termination of resuscitation rules for out-of-hospital cardiac arrests, and that is something that is both resource-wise but also ethically permissible for those dire cases of a patient who has an out-of-hospital cardiac arrest. They also describe a little bit the acceptability of conditional CPR, for example, based on the initial rhythm and whether it's shockable or non-shockable. And it spends a significant amount of time talking about the need for greater education and attention to these DNR and guidelines, showing the evidence of multiple randomized controlled trials that show that healthcare professionals who receive formal ethical education report greater confidence in their decision-making, better alignment with patient values, and reduced moral distress in these challenging situations. There are several systematic reviews and observational studies that back that up, further indicating that structured training enhances ethical decision-making and reduces some of that provider-to-provider variability in practices. There's some data as well that simulation, I think we talked about that resident case and other studies that show that simulation improves the ability to handle DNR discussions and decreases some of the hesitancy and the ability to promote ethically sound interventions. There are 2 regions with publicly accessible perioperative DNR-specific guidelines, one of them being for anesthetists or anesthesiologists practicing in the UK and Ireland, and the other for those in Australia and New Zealand. This is a guide from the Association of Anesthetists from UK and Ireland that advises that clinicians should be having those early preoperative discussions. They should try to both understand and document patient values, preferences, wishes, and what they would consider as the patient appropriate or desired interventions. However, this guideline makes it very clear that it's usually appropriate to suspend, and they also clarify that any DNR forms are not in fact considered orders in their countries, but recommendations, and as such, they're not legally binding. The court has also made it clear that clinicians should discuss with the patient or appropriate surrogate, but any sort of active DNR or any advanced directive really aren't considered forcibly applicable to the OR environment, and they're not required to follow them in the real-time decision of CPR. Fascinatingly, this writing group also states that certain treatments, including CPR to circulate drugs or defibrillation, they don't even consider resuscitation and would not be subject to any limitation. This is in distinct contrast to the Australian and New Zealand guidelines on perioperative DNR management, which are much more assertive and parallel or align a little bit better than what we see in America. Their version reiterates that automatic suspension is no longer an acceptable ethical approach, and clinicians do have a duty to critically assess the end-of-life phase that the patient is in. They go so far as to say it is inappropriate to offer surgery for patients who are imminently dying, which they described as active dying with death expected in hours or days. I wonder how many of you have cared for a patient in the OR with an imminent death expected in hours to days. All the time. All the time we care for these patients. They also are assertive in their warning of clinical momentum, initially described in ICU populations where the automatic offer of a cascade of increasingly invasive interventions without a critical evaluation for the benefit of those interventions or the consideration of alternative actions. They talk about this being particularly germane to a perioperative patient, where you can see the concept of surgical buy-in, that if that patient consented to the primary surgery, they consented to everything afterwards, and the increasing intensity of whatever complication might arise. Finally, we can see for the greater than 3 million surgical procedures completed around the world every year, there's significant differences in how perioperative DNR orders are managed. There is certainly good evidence to say that automatic reversal of DNR orders is happening in the United States, but also significantly abroad. There was a really interesting 2019 study in the Netherlands that found that 80% of anesthesiologists would automatically suspend all DNR orders, and furthermore, if a patient with an active DNR experienced cardiac arrest in the OR, more than 70% of Dutch anesthesiologists would start CPR anyways. In that study they did, it was actually the Dutch orthopedic surgeons who were more likely to honor a preference or try to understand how they could respect the wish of a patient perioperatively. It's also unclear to what extent providers are disclosing these decisions to patients and families, hearkening back to that study where maybe 4 to 7% wouldn't even inform the patient they were automatically reversing. There was a 2016 Swedish study that found that more than 70% of their DNR orders had been unilaterally placed on patients and never discussed with patients or families. So we find patients' families blindsided in both directions. Even in countries like the US with well-established laws, good professional guidelines, there's reticence on how to manage these respectfully, logistically, and appropriately perioperatively, and it's not always clear. Our path forward, however, is clear. There has to be greater transparency, and there has to be more work towards shared decision-making, but also we can see the power of formal training around how to manage these code status limitations for the benefit of the patient that deserves goal-concordant care, but also for our colleagues who are shouldering the burden of these difficult decisions. Those are references for you. Thank you.
Thank you. So with that, I kind of want to thank all the panelists for being concise and kind of to the point, and that's really fulfilled an important goal that we all had at the conclusion of this, was to hear from you all and engage in questions and kind of any kind of thoughts and comments you have. So please speak up. I think we've seen a notice here that they prefer questions to be addressed into the microphone, if you can, so don't be shy.
I've got a couple.
If you can just tell us where you're from, and is it not on?
Okay. It doesn't seem like it's on.
Sorry, go for it then.
Yeah, so I have two questions, one of which is like very tangential, so I may wait to see if anyone else has other related questions, but since you all think deeply on these topics, it's a little bit related and I would love to ask it. But the one that's more relevant is getting into the weeds on the involvement of the surgeon in a policy. You know, I would hazard to speculate that like a fourth of the time when our surgeons book a surgery on a DNR patient, they didn't even know the patient was DNR, okay? And so I feel like the policy should describe the surgeon being required to engage in that conversation before they even book the procedure, because it's really not appropriate for the surgeon to be booking a surgery if they don't even understand the patient's goals or wishes related to, you know, how far they'd want to go with life-sustaining measures or whatever. So I was just curious, have any of y'all in the weeds of y'all's organizational policies gotten really granular about like the surgeon having to have had that conversation before they even booked the surgery? Anyone?
I think in the guidelines, it says that if it's not an emergent procedure, the primary team, which is often the surgeons, they will have to have that conversation. So the procedures, for example, if I'm giving anesthesia, I will also have a conversation, but there has to be a documentation of the code status, required reconsideration by the surgeon.
You know, I want to have the conversation too, but I just think that the surgeon should have
Yes,
had it, because
you're
I don't
right.
want them ever getting in the situation where they're doing a surgery without being aware, for
Yeah.
example, that the patient doesn't want any resuscitation done.
Correct.
And they're like thrown off by that. I don't know, so I would like to find a way to like actually describe that in the policy, and so I'm just curious if anyone has that. And I don't love the idea of keeping it general and saying the primary team. I think it should be like the proceduralist before they're allowed to book a procedure.
Yes, you're right.
So just to go along with what Shala's saying, you know, my institution has that in their policy, exactly to your point. The problem is that we still have cases, where we present to the OR where the surgeon has no idea about the policy, and it's a journey of discovery for them, when this actually comes up, usually during the kind of the pre-op huddle there, when we're just talking about kind of, goals, and the patient has expressed the wishes to be DNR. And it's like, what? And this is a complete surprise to them, because, and let's be frank here, for many of our surgical scenarios, especially in the academic centers, this may be the first time the attending surgeon has actually seen that patient in the flesh as well. But, any other thoughts on that?
If you can figure out how to get surgeons to even look at the patient pre-op, I'll nominate you for the Nobel Prize in medicine. I mean, it's impossible.
Yes, sir.
I have a question, which is, there are a couple of them. One is operational, which was aligned with this one. So I'm not sure what other institution, but my institution to have, even looking at the chart, the EMR, it's very difficult to find where this DNR order exists. So few of our pre-op nurses are expert to look particularly in that area or dig into the chart. But is any other different institution has any different ways to have pop-up window comes up, is the patient is DNR?
So Epic
So
has,
The safety measures, to me,
Yep.
it's like, it has to be like an allergy ban, everybody should be walking around with a DNR tag.
do you have Epic in your institution?
No, we have
Cerner?
Okay, Cerner has a place where it's in the top bar. You can click on it and see the code status, which is the current code
So
status.
our system doesn't have it.
I-
And I asked with the IT, fighting with them for years,
Yeah.
that allergy
It's-
should be listed as like DNR.
I think it's common to the majority of EMRs that there is actually an option to advertise there what the true status of the patient is in that regard. Now, getting your hospital IT to implement all the possible options that there are within the EMR can, again, like issues with our surgical colleagues, can be proved to be more of a challenge. But the facility is there. It's a question of just implementing and then administrating that. So I think you can, quite strongly sort of go back to your institution and say, yeah, other people are doing this with this software, so why aren't you?
Does any other institution carries like a band or something?
I have seen that at other institutions where, once that is put in, a wristband is put on, and that might be an easier fight for you than getting IT to make changes.
Especially if you already have a system of like fall risk or other
Right,
ban, if you have a banned system that's
Yeah.
already occurring, you might be able to hijack it.
And the second one is the ethical question. So if you're on call then after hours, you're the only physician, and there's a disagreement between your values and what the patient's values are, obviously there is nobody to transfer the care. What do you do in that?
That's a good question. We've kind of talked about this, which is essentially the kind of tension between your duty of care to the patient and, but at the same time, respecting your own moral conscience. But Shala has actually written in the ASA mantra on this. Do you want to take this?
Yeah, so, whenever there's a conscientious objection, there is a procedure for it. Anesthesiologists are not allowed to abandon their patients at any stage. So at the time of the care of your patient, if they're under your care, the only way you can get out of it for any moral conscientious decision is if you can transfer the care, and the care should be seamlessly transferred to somebody else who is of equivalent. You can't transfer the care to a resident. Has to be an attending level person. Now, if you're on call and you're unfortunately in a situation where there is a conflict, you might want to call in somebody, or you might want to call in an ethics consultant if you have one, or if you have a chief of your department, if you want to. But depends on how strongly you morally feel. But there has to be a situation, a policy again in your hospital which takes care of these. For example, in our hospital, performing abortions or gender affirming care, reaffirming care. We have a list of anesthesiologists who object to that, and they can go and quietly put their names on it. The schedulers will not schedule those cases. But in an emergency situation, if that case arrives in your OR, you cannot at that point say, I'm not going to take care of this patient, because you may be on call, or you may be, the patient may be hemorrhaging for any reason. You have to deliver care to your patient.
And I think that point about actually you having a professional responsibility to your colleagues and to your institution to disclose your thinking in this regard is very evident. This is not something that needs to be discovered at 2 o'clock in the morning. This is something where you should have actually said to your colleagues, I've got a real problem here with this scenario. And the question then, perhaps rightly, in some circumstances may be, well, do you have a future here in this institution if this is the type of work that is done? I think we all understand the importance of adhering to one's internal codes of conduct, but at the same time, we have this strong impetus towards a duty of care. And if you do have issues with that moral conflict, I think it is beholden upon you to advertise that beforehand with colleagues and with your home department, so that you can at least see whether this is possible to accommodate this. So at the end of the day, we're not doing the thing that we all want to avoid, which is harming the patient. Yes, sir.
So my personal connection to this is that Karen Ann Quinlan was at my hospital before I was.
I was going to say you've aged well, if that was
I finally got our hospital to do away with automatic rescinding DNR about 5 or 6 years ago, maybe a little longer. So that's finally done. But personally, and I may be naive in this and everything else, so I personally view, pushing a little ephedrine, phenylephrine, maybe even norepinephrine in response to something that I did as not resuscitation.
Yes.
I do not generally break the conversation down into maybe one shock, a couple chest compressions, whatever. It's sort of, if it's something I think I did, it's usually pretty fixable. I would recommend at least giving some attempt to fix it.
Yeah.
And they can take it or leave it. But that's usually.
And most patients agree to that. I mean, if you have, we have to assume that most patients come with the same medical proficiency, well, not the same medical proficiency, but some information or some understanding of what we do for them. And when you explain it that way, that, look, I'm going to give you drugs which will lower your blood pressure, and I have in my ability to reverse that effect, I think that is appropriate. And most patients, I do that all the time. I say, my drug propofol will do this, and I think we should come back to your baseline so that you have a natural trajectory, and they agree to that. But then I do mention that if that precipitates a heart attack or something more catastrophic, what it would take to bring you back to this baseline would be an electrical shock, and would that be within your goals of care? So that further scenario, depending on how sick the patient is. If it's unlikely, then you don't have to describe every morbid detail.
As has been said, I mean, this is not, we've got lots of medical opinion on the topic, and there's relatively few studies that have directly involved patients. But of the few that they have, there's one by a guy called Burkle from about 2013, I think, if I'm remembering correctly, where he actually interviewed patients on what would you want in this DNR setting? What would you want your medical professionals to do? And the vast majority of your respondents, over 92% of them, said, okay, I'm aware that this may get, things may get rescinded, and I might agree with rescindment, but I want to be involved in the discussion. Just making an automatic decision one way or another is not acceptable. And so I think we can take that as the kind of mileage required, the ammunition required, to go back to our hospitals and say we have to engage patients more and respect their autonomy one way or the other. I've seen these preoperative discussions go both ways. I've seen people come down with DNRs who have said, oh, no, actually, I didn't understand what I was agreeing to earlier on. I want to be resuscitated. And so we said, yeah, okay, that's fine. We will actually respect that and revoke the order, etc. Obviously, you see it sort of going the other way with people being pressured into those settings. But I think the key message here is that patients have to be involved in these discussions as much as is humanly practicable.
That's my problem with the armband. So just like you can have errors in medication alerts, et cetera, it just takes somebody dropping the ball in not updating the order, and someone comes down with a DNR order and you do not administer CPR based on that armband, and they are actually full code. It's something that is devastating. So it will just take one student nurse not updating the armband. And so that's why it's important to have it in the EMR and the date. Like Epic gives you the date when the order is right in where the patient's name is and the MR number. That's where the DNR, the code status is written in bright red letters with the date.
Yeah. And I don't think there's a magic bullet to this discussion. I think probably the best approach is to try and cover as many bases as you can. Have a banner on your EMR. Have a bracelet if a bracelet works for you in your institution. But the most important thing is make it part of your workflow that this is a considered element of discussion. I think that we can all do that individually and exhort our colleagues to. Yes, ma'am.
Just wanted to get your thoughts on a few situations I've been in. Once I had a patient who was coming for a procedure who was supposedly DNR and supposedly had dementia. The primary hospitalist who had admitted her had instituted a DNR order with her daughter. And when I was talking to her, she was not aware of this and she wanted to resuscitate, but then said she had dementia. And so, what do we do here?
Interesting one. I know what I would do, but yeah. Anyone want to pick?
Constant, if you don't mind.
Oh, please, please, please.
Constant question from the residents to me. There's a simple test. It's called the mental capacity test. 4 questions. And if even people who have psychiatric illnesses or dementia, unless they're obtunded in front of you and they can answer those 4 questions, they have capacity then. You can have that discussion and document that the patient had capacity, and you do not need a psychiatrist. Orthopedic surgeons love psychiatrists to document it. They will not talk. You can, if you can, like you said, Nobel Prize, you can get an orthopedic surgeon to talk to a patient. But you just have to ask them that, what are you coming for? What are the advantages of this procedure? What are the risks of not having this procedure? And what are the complications of the procedure? If they know all of this and they still want the procedure, they have capacity to sign consent and change the code status. So if she wanted to be, and one rule I've lived by most of my life as an attending is, when there is a doubt, err towards life, because that is, not irreversible as death is. So if you have any discussion with the patient and they want full code, very often it's the reverse, but in your case, it was they want full code, and then you do not resuscitate them based on someone else's opinion, you can always go back and change the resuscitation order, but you can't bring them back if you haven't resuscitated them. So I always err towards life whenever there is a doubt and you don't have time.
I think that's a common misconception also, that you need to have psychiatry determine capacity, but any physician can determine capacity. So as anesthesiologists, we are fully capable of making that determination.
And I think
And
she might
sorry,
not be able
go.
to tell you what she had for breakfast, but if she can describe her life and what matters to her and what a good day is, you may be able to gather enough information just in that 5 minutes to say, you can describe enough to me about what's going on and what you value, that I can make a judgment call as a professional and make the right choice for you in this very unique environment, knowing that statistically, most patients, even with a decidedly DNR order in place, would choose to reverse for the OR. You'd be in good standing.
Yeah, and I'll just make 2 kind of quick points there. Again, like you heard, I think we use labels a lot on conditions that actually enjoy a spectrum of severity. And so the extrapolation of what are going to be inevitable consequences of the setting are probably unwarranted a lot of the time. So I think we have to bear that in mind. And secondly, I think I am personally rather careful about situations where surrogates have made decisions about DNR, because I have come across too many situations in my career, admittedly grey and on the exit ramp of that career, but too many situations where surrogates have had their own agenda in terms of making the decisions for some of their relatives there with that. But, yeah, sir, you had another question.
I would just point out that a lot of my patients, even who do have capacity, would not be able to answer all 4 of those questions. Because the surgeon has never had an adequate discussion.
I mean, that's a whole nother problem, right?
That's not from comprehension.
Yeah,
that's
that's a
just
whole
from
different discussion.
lack of information.
Right.
The consent is not informed.
One more question, because we'll probably have to wrap up and let the staff go, but because we're 5 past. But
I have, like personally, I think that if the patient coming from ICU, my ICU, have patient on 4 different vasopressors because they are vasoplegic for whatever reason is septicemia, maybe they dead bowel. And to me, there's all resuscitation that's been going on for a day or more. But they still have a DNR status and nobody has talked in ICU. Now it lands on my job to figure that out or convince the patient or family and something like that. To me, that this patient was already in ICU on bunch of resuscitation. To me, is that the resuscitation? Is that a different thought process or different?
So here they probably mean CPR, DNR versus
No, but they
CPR.
haven't even discussed that. So to me, it's like, is that something that my thought process is different than other thought processes? That is that not considered as a resuscitation?
Well, that's wrong practice. There should be a documentation. If you go back and read the notes, there must be a documentation of goals of care discussion. If the patient is DNR, there has to be. Legally, it's not allowed to just put in an order without a documentation of what the goals of discussion were.
But again, remember, DNR doesn't mean you don't treat the patient, right? So if a patient has sepsis, I'm going to, as an intensivist, I'm going to give fluids, I'm going to give antibiotics, I'm going to give vasopressors because I'm treating that underlying cause. Just because a patient has a DNR doesn't mean I'm going to withhold.
Yeah.
And you're right, that is, fluid resuscitation, things like that. But it doesn't mean that I'm going to withhold those treatments.
So I want to thank you all for an engaging set of questions, their discussion. Hopefully we've done at least an incremental part of what the goal was here, to educate and discuss. And kind of my challenge for you all, as I said, on the exit ramp of my career, I think I've seen a situation there that I'm continually recycling the discussions I have. Things that I assumed were set questions, 15 years ago, that set answers rather, are learning that you need to revitalize these discussions, you need to bring them back up. And so my kind of request to you all is to go back to your own individual institutions and say, hey, I was at this talk, what do we do here? And just question your colleagues. Make the issue resurface and be provocative and just saying, okay, have we actually talked about this or done anything within our department? I think that's the only way we will continually evolve our understanding in this situation. But thank you all for your attendance, and I appreciate the questions.